Myocarditis and pericarditis. Itis meaning inflammation, so inflammation of the myocardium or the pericardium. Now, myocarditis is going to present bimodally in young adults and then again in older adults. And then pericarditis is typically a disease of the elderly. Now, myocarditis is noteworthy because it involves a hypertrophy of the myocardium due to the swelling engendered by the inflammation, the itis part of it. And this hypertrophy can stretch subendothelial conduction bundles, which are right next to the myocardium. And the pressure and stress on these conduction bundles can engender an arrhythmia. And in a young adult, this can lead to sudden cardiac death. So the arrhythmia causes your heart to stop beating, and the two most prominent causes for that arrhythmia, if they're not an inherited arrhythmic syndrome, are going to be myocarditis and hypertrophic cardiomyopathy. There's a lot inside this SDL. A lot of it you won't get tested on. Let's start breaking it down. Myocarditis, inflammation of the heart muscle due to exposure to external agents or internal triggers such as autoimmunities. Very common following a viral infection. And as we know, you can get an endocarditis or a pericarditis subsequent to a viral infection. You may also have an autoimmunity target, any of these three layers of the heart or all three. That's called a pancarditis. So there's so many different ways that you can get this that's not going to be a frequent subject of examination questions. What they're more likely to ask you is, well, now that the patient has this, what's going to happen? Or there's also different things that look similar to different aspects of the myocarditis. Again, the hypertrophic cardiomyopathy is going to be one. So that's another route of questioning too, rather than why do they have this? They might show you a histology slice of the heart and it's got a lot of lymphocytes and you have to infer myocarditis rather than cardiomyopathy, right? So that's where we're going. Wide range of clinical presentations. Sudden cardiac death is the one to know. Heart failure and arrhythmias are the two worst complications. Myocarditis can lead into a dilated cardiomyopathy. And a dilated cardiomyopathy is basically going to be a systolic dysfunction progression into heart failure. And that means it's going to have a reduced ejection fraction because as the heart fills up with more and more and more volume according to the degree of its dilation, it's not going to retain the ability to perform Frank Starling compensation. We know that whenever you put volume into the heart, Frank Starling says the more volume you put in, the more snapback or contraction you get. But with a weak myocardium, this is not the case. And so anytime you have a myocarditis, which is going to be inflammation of the myocardium, or a cardiomyopathy, which is going to be a usually inherited or sometimes acquired disorder of the myocardium, you can see that the loss of systolic function is going to result. Could be a loss of diastolic dysfunction. That's going to be saved for the cardiomyopathy SDL, but you can see the loss of diastolic dysfunction in the pericardial diseases later in this SDL. So myocarditis can segue into dilated cardiomyopathy. And we define myocarditis histologically with the Dallas criteria, which this author really hates. Really gets into digging into the Dallas criteria. But what you need to know is that two things in the Dallas criteria. Number one, immune cells, namely lymphocytes, usually lymphocytes. And then number two, myocyte necrosis. So there's an immune reaction, and alongside that immune reaction, the cells of your heart are dying. So if the cells of your heart are normal and there's an immune reaction, you don't have enough to call it a myocarditis, right? You can call it a borderline myocarditis, but it's not going to meet the check that you need to diagnose it. This is often a clinical diagnosis, because it is very tough to biopsy the affected tissue, and we can biopsy it, but again, it's rare and it's only for patients whose life we need to whose life is in acute emergent danger. Most cases are believed to be subclinical. You can live with a myocarditis. You can get over a myocarditis just fine, and it may never come back. We've got a table listing all the etiologies. Again, so many different things. Don't worry about this, because if it's a myocarditis, you're going to see symptoms in a question stem that lets you know it's a myocarditis, right? So you're not going to have to worry that much about making the diagnosis as long as you can put 2 and 2 together and figure out what's going on as the myocardium hypertrophies and swells, and you get this systolic dysfunction because this segues into the dilated cardiomyopathy. Bimodal distribution, young adults, children, then again in the elderly. Primary versus secondary. Well, primary is when we don't know what's causing it. Secondary is when you have some other condition leading to a myocarditis. Most cases of primary myocarditis are going to follow a viral infection. So what kind of viruses? Number one, predominantly Coxsackie virus. And this is the most common, most likely, if they just ask what's the most likely viral agent, Coxsackie virus, right? So our sketchy for this is the Coxsackie cockatoos. Remember, you have an A and a B variant of this, and the A is going to give you hand, foot, and mouth disease. And specifically with the hand, foot, and mouth disease, you get this symptom called herpangina, which means blisters on the inside on the mucous membrane of your mouth. And then with Coxsackie virus B, you're going to get pleurodynia, which is going to be basically a chest pain of the pleura. It's called the devil's grip. Remember in the sketch, we've got this zookeeper with red gloved hands putting his hands on the cockatoo, and that's our visual metaphor for the chest pain of the pleurodynia. What are some features of this virus? Well, it's an enterovirus, which is a specific type of picornavirus, or a pico small RNA virus, and it's a single-stranded RNA virus in its positive sense because the sketch occurs in the daytime. It's an RNA virus because the sketch has warm colors, and it's transmitted via the fecal-oral route. Its big virulence factor is going to be the fact that it binds to the CAR, Coxsackie adenoviral receptor. And once it binds to this receptor, it gets inside a cell and it'll lyse the cell and kill it. And so because you express Coxsackie adenoviral receptor on cardiomyocytes, Coxsackie virus and adenovirus can get into the cells of your heart and pop them open from the inside out. And this is going to cause local inflammation and eventually scarring, right? And so this is going to lead to the dilation of the heart over time as it can no longer contract properly due to all the scarring, and it'll just expand, and there's your dilated cardiomyopathy, right? So then we've got adenovirus as another common cause, and our sketch for that is going to be adeno-lions, and it's adenovirus like adenoid tonsils, because that's commonly where the virus is going to bury into and make a home. So this is a double-stranded linear DNA virus, cool colors. It takes place in a cave. There's a lot of lions in this cave. Remember, there's a kid in a pool, right? Because this can be transmitted through swimmers. There's a lot of lion poop on the floor, fecal-oral route, and let's see, what else? Causes a conjunctivitis, can cause a gastroenteritis, can cause intussusception of the bowels or telescoping. And the symptoms that you see are going to be correlated with the route of infection of adenovirus. And so if it's transmitted fecal-oral, you're a lot more likely to get the GI side effects and then thus the myocarditis secondary to it. So if your patient's got an upper respiratory disease only, or maybe a stomach ache, that's when I'm thinking adenovirus. But if they've got the rash in hand, foot, and mouth, or if they've just go straight to the pleurodynia, the chest pain, then that's more likely to be Coxsackie virus. And then the last one that we talk about specifically is parvovirus. Parvo meaning small. It's the smallest DNA virus, and that's represented in the sketch with the small runway for the small planes, and the planes are B-19 bombers because parvovirus B-19 is the specific type of parvo that we're worried about. And it can cause slat cheek syndrome, also called erythema infectiosum in kids. And it's going to be a rash that starts on the face and moves downwards over time. And then the other population that parvo likes to infect is people with sickle cell, because parvo binds to red blood cells because of this P antigen. And parvo binds P antigen and goes into blood cells and then pops them open from the inside. And so this is the same thing that it does to cardiomyocytes when it binds P antigen, which is also expressed on heart cells. So parvo's bad again in two populations: kids with rashes on their faces and patients with sickle cell anemia. And so if they don't have one of those two things, it's way more likely to be Coxsackie virus. So what does myocarditis look like clinically? Well, sometimes they'll report an antecedent virus, sometimes they won't, sometimes the virus is self-limited and so subclinical that the patient doesn't even remember it, right? The heart's going to be involved, and there's three big timelines here. It's going to be fulminant, acute, or chronic. And this page 7 here, is basically telling you what the question stem is going to look like. You know, it's, if it is a question about myocarditis, then it will be a patient presenting along one of these three timelines. So fulminant, abrupt shock, they go straight into heart failure. Tachycardia to compensate, right? Echo is going to reveal a floppy heart, basically, that's got diastolic dysfunction and a lot of scarring in it. Acute myocarditis is going to be the same thing, but it's going to have a little bit of a gentler slope to it. You're going to see ST segment elevation on ECG. You're going to see wall motion abnormalities. Troponin will be released. Why? Because the muscle of your heart is dying and bopping open, and its membrane is being ripped apart. That's going back to the dystrophin. Cells can't maintain their membrane whenever they're not linked to the cytoskeleton. So we get the definitive diagnosis with an endomyocardial biopsy. This is way cool. We go in and we'll snip a little bit off of the right interventricular septal wall, and we'll pull it up and out through the neck, and then we'll put it on a slide and look at it, and we'll see if there's lymphocytes, essentially. Although there are other types of myocarditis. And we know that for it to qualify as a myocarditis, it has to meet the Dallas criteria, which says that there has to be a lymphocytic inflammatory infiltration. Well, not lymphocytic, any inflammatory cell infiltrate. There's got to be immune cells, and then there's got to be cardiomyocyte necrosis. So you need both those things. And if you only have one, it's borderline myocarditis, not pure myocarditis. And if you have neither, it's negative. So what are we looking at here? Well, I see cardiomyocytes on this lower right corner of the picture, and then I see a tiny little swath of them up here. I see some cardiomyocytes, particularly around the capillary, but then the whole rest of this histoslide is just immune cells, like all the way down. Everything else in this slide, all that blue, all that is immune cells. And so do you think there's some myocyte necrosis occurring there? And my answer is yes, because there's almost no myocytes. You know, the heart should not look like that. Compared to a borderline myocarditis, in which you can tell that there's a lot of myocytes here. And none of them look particularly wimpy or shredded. And those would be signs of myocyte necrosis, but you don't see those. And the lymphocytic infiltrate, it's not very widespread. It's kind of it is infiltrate. It's infiltrating in between heart cells. And so because it just kind of stays in between, it's not too egregious. We're going to call this a borderline myocarditis. And both of these are lymphocytic myocarditis. Now, grossly, you can see microabscesses, which is going to make sense because that means that you've got to have a sporadic pattern of damage to the heart, right? And so if it's an acute MI, it's not going to be a sporadic pattern of damage that you can see from the outside. It's going to be like a big region, like one whole segment of the heart is going to be blazed. But with a myocarditis, it's a patchy multifocal distribution that you can see from the outside. So you know, okay, there's foci of inflammation here. And you know that's not going to be a heart attack. Here on the right, we see really wide heart, basket-shaped heart, U-shaped heart. Does that look dilated? Looks very dilated to me. Cardiomyocyte damage may appear as necrosis. You might have to look a little bit harder. Here we see some scarring within the myocardium. It's healed up. There's some, and there's some, and then there's a big septal region here. So what's more common? What's more likely? The patient had acute MIs in 3 or 4 separate places, or the patient had a myocarditis. And the answer to that is probably going to be the myocarditis. It's just an 8-year-old child, you know, and it's like, that's not an MI right there. So grossly, you see ventricular dilatation. You can get wall thrombi because there can be wall damage. Endothelial damage. How can the endothelium get damaged if it's a myocarditis? Well, all of the immune component. Remember, we're saying T cells and B cells are investing into the heart, and they're spitting out cytokines that are going to encourage local inflammation. Well, that inflammation can reach the endothelial layer and damage it and cause it to peel itself back, reveal all that collagen underneath, and that's how you get a thrombus. Late stages of myocarditis may show focal or diffuse fibrosis. This goes hand in hand with the scarring. That is the scarring. The distribution of fibrosis is random, as opposed to the subendocardial fibrosis typically seen in ischemic heart disease. Because again, anytime you have a heart attack, it's got to be a specific region of the myocardium corresponding to whatever blood vessel just got knocked off. So if it's patchy and sporadic, it's unlikely that it's going to be minor heart attacks at all those different places. Specific pathological forms of myocarditis, lymphocytic by far most common, and then within lymphocytic, the most common cause of that is going to be Coxsackie virus. Again, compare the symptoms. We're thinking upper respiratory or GI infection, that can be adenovirus, and then sickle cell patient, child, parvo becomes more likely. Poliovirus is going to replicate in the brush border in the enterocytes of your small intestine, and then poliovirus, the sketchy for that is a flamingo pool, and that's also a positive sense single-stranded RNA virus. It's going to be an enterovirus, just like Coxsackie virus, and it's also a picornavirus. Echovirus, same thing, enterovirus, picornavirus. Influenza virus, this one's interesting. This one is going to be a negative sense RNA virus, because this one takes place at nighttime. And the sketch for this is the dentist's office. And so you got 2 strains, flu A and flu B. And I mean, it's going to be super general. You're not going to get a test question about this. Human herpes virus, that's if the patient's got big blisters or boils on their lips or genitalia. That's going to be cold sores with HHV1, and then genital lesions with HHV2, although you can get either with either, so don't be thinking that they're pathognomonic. Cytomegalovirus, we're not going to have to worry about that, really. That's a disease of the newborn. And then HIV, you guys know what HIV looks like. So bottom line is, we're going to be biopsying a patient's heart. We're going to be taking a pinch of heart muscle and endocardium away from the heart, and we're slicing it up and putting it on a slide, and we're going to see what it looks like. And if there's a lot of lymphocytes there, we're thinking virus. But then if there's different things there, we're thinking different underlying pathologies. But you got to know the most common is going to be a virus with a lymphocytic infiltrate. The lymphocytes, all the helper T cells, all the Th1s too, that are going to be attacking cells containing viruses. That's a lot of lymphocytes here. They look like poppy seeds. You can tell that the myocardium up in this rectangle I've just drawn is really wavy and detached from one another. And that's one of the first signs of myocyte necrosis, right? And that's also due to the congestive heart failure. There's a lot of edema in between individual cells here on this slide. So again, most common type, lymphocytic. Giant cell myocarditis, very, very rare. You're just going to see giant cells along with lymphocytes. It's frequently associated with arrhythmia, but I'm assuming that all of these myocarditis are associated with arrhythmia. That's nothing special. There is an association with thymoma and Crohn's disease. Both those are autoimmunities, and thymomas in particularly are related to, what was it? Dermatomyositis, I believe, that we saw in musculoskeletal block. Granulomatous myocarditis. Oh, so side note, remember that the thymus involutes with age. So if the patient's 30 or 40 and they've got a big prominent thymus, that's when your suspicion for thymoma should be very high. Granulomatous myocarditis, same thing as the giant cell myocarditis, except you're going to see giant cells inside a granuloma, which is going to be like a swirl or a whirlpool of epithelioid macrophages. And this can be caused by sarcoidosis or by tuberculosis. And TB is really, really common in countries outside America comparatively. So there's still a great many TB questions on boards. We just haven't gotten one here at school in a long time. Then you can have an eosinophilic myocarditis, which predictably is going to have lots of ruby red eosinophils. And you ought to know what those look like on histology by now. And this is typically due to a pharmacological reaction. You can get this thing called DRESS syndrome, which is going to be a direct basically eosinophilic activation. So when do eosinophils traditionally get activated? Well, something's going to present an antigen to them, and then they're going to be activated to make IgE. And that IgE is what helps mast cells degranulate. And so eosinophils are indeed involved in the type 1 hypersensitivity. But sometimes it's not always an antigen, rather, sometimes the antigen is from something that ought not be antigenic. And that's the drug reaction. It's going to be a hypersensitivity against an offending drug, meaning that for whatever reason, a patient is having an allergy, an allergic reaction to vancomycin or tricyclic antidepressants or whatever the drug is. Toxic myocarditis, caused by biologic toxins, so don't get it confused with a drug-related myocarditis. A toxic myocarditis, the example that they give us here is going to be Corynebacterium diphtheriae, which the sketchy for that is a bullfight, and you need to know that it's got this elongation factor 2 toxin that's going to stop the ADP ribosylation of proteins. And what else about diphtheria? It can involve a neuritis alongside the myocardial damage. You're going to see it on Loeffler's medium or Tellurite agar. And it's going to lead to this dilated cardiomyopathy as the myocarditis progresses. So again, common theme, start with myocarditis. It doesn't go away. It progresses into a dilated cardiomyopathy with a low cardiac output and a systolic failure. And this is what the diphtheria myocarditis looks like on histology. Pretty general, just hyaline degeneration, cardiac necrosis, fat accumulation. So let's get into Chagas. It can cause a myocarditis as well, and it's endemic to 21 countries in Latin America. Chagas is a protozoan. It's a parasite, basically. And our sketch for this is Che's gas. And being a protozoan, it can get inside cells and replicate inside cells, much like a virus, but this is going to be a biological creature. So it's got this amastigote form, Trypanosoma cruzi does, in which it goes latent inside cardiac myocytes. And this is what you see here is a myocyte sliced axially, and you're looking at basically parasite eggs inside of it. And then it's also got this, it's got another form. I'm forgetting what it's called off the top of my head, but then you've got this other form of trypanosoma that's going to look like a malaria almost. I'm forgetting the word for what this dang thing is called, but if you see something that looks like this in the bloodstream on this STL, it's a sure bet for trypanosoma. So what do the symptoms look like? Well, myocarditis is the most noteworthy, but then it's transmitted by this thing called the reduvid beetle, also called Triatomine, and that's the vector. And it can inject trypanosoma into your bloodstream basically whenever it feeds on you, and it typically feeds around the eyes. And so patients will present with one eye swollen shut like that, right? Because that's where the bug bit them. And that's called a Romanes sign. And that's a pretty sure sign that you've got a cardiomyopathy in your not too distant future. So again, nothing surprising here. Dilated cardiomyopathy, possibility of thrombi, possibility of aneurysms due to the thinning of the ventricular wall, possibility of arrhythmias. Here you see an immunohistochemical stain, which obviously they're going to have to tell you what they're staining for if they give you this on the test. No big deal. And then here, all the dark dots are going to be myofibrils, myocytes, basically. And you can tell that there's basically no myocytes in the upper right quadrant of this picture. And that's what clues you into the fact that there is some heart necrosis going on, because there ought to be heart cells there. Lab findings are non-specific. If you see high white count, then you're thinking bacteria, maybe fungi. White count won't be that high in a virus. Eosinophilia clue you into a drug reaction. If you see a high lymphocyte count, if you see a lymphocytosis in the blood specifically, not a neutrophilia, but if you see a lymphocytosis in the blood, then you know that probably a viral infection or an autoimmunity, and either of those can cause a cardiomyopathy. Heart enzymes being elevated is not that big of a deal. It makes sense. We can diagnose it with an MRI, gold standard. We can also diagnose it with an echo, and on both, we're going to be picking up wall motion abnormalities, the degree of ventricular dilation of a given chamber, and then also a general hypertrophy of the heart. So it can be worked into a question stem either of those two ways with a dilated hypertrophy, dilated cardiomyopathy, right? So myocarditis will go away by itself most times, and myocarditis can recur. That's the most common complication. Heart failure, I would say, is the worst complication. So that's two ways that question can get asked. What's the most common? What's the most lethal complication? It's in that paragraph. So myocarditis is a bit of a bore, bit of a drag, as you can see. It's kind of saying the same thing over and over and over again. Big keys. If you see lymphocytes, you're thinking of virus, and then you make the diagnosis based on the symptoms. It can lead to sudden cardiac death because it disturbs conduction pathways. And that was not mentioned. That was mentioned like one time at the start of this SDL. And that's probably going to be where the question comes from, because anytime a 25-year-old just kicks it, obviously people want to know how they died, and that's only mentioned right here on page 2. So because it's only mentioned once, they're trying to sneak a fastball past you, Just be ready and hit it. I'm going back over myocarditis in review, and there's not that much that you can ask there. There's what's the most likely viral agent, but that's going to be Coxsackie 8 times out of 10. The timeline of the pathophysiology, that makes sense. You can answer that question without even studying this. What proteins are going to be affected? Dystrophin, things linking the cytoskeleton to the membrane, and then other components that connect cells to each other, such as laminin. It can be not bad, bad, or really bad. but they all kind of present the same way again with that dilated cardiomyopathy. We biopsy the heart. We see lymphocytes on slides most of the time. You probably won't get a gross image, but if you do, it's going to be a dilated heart. You can have scarring. Again, this is in an 8-year-old, showing that you can get myocarditis at a very young age. And then there are a lot of different types that they kind of all look important. There's a lot of real estate dedicated to them here in the text, but really you got to know lymphocytic and eosinophilic. And Chagas, finally, that's so unique that you ought to be able to spot that from a mile away. So let's get into pericardial diseases. This is a bit of a challenging taxonomy, because within the text it lays out pericardial effusion, acute pericarditis, and chronic pericarditis. And what I want you to know right off the bat is that the mechanism in all of those is exactly the same. It's an inflammation of the pericardium. And it really doesn't matter how it gets there. It just matters how long it goes on, and does it self-resolve or does it stick around? So that's going to be what separates the general phenomenon, the idea of pericardial effusion, from the specific presentations of acute and chronic pericarditis. And then you can have little twists within acute or chronic, but that's the main idea, is that there's inflammation of the pericardium across all these disorders. So how does that present? Well, typically chest pain. And you might hear a friction rub, which is going to sound like walking in crunchy snow. And you can have shortness of breath. You can have trouble breathing when you lie down. And the reason for this is because your heart has a diastolic dysfunction. So it can't fill up properly. And the reason it can't fill up properly is because it's basically wearing like plate armor, you know, like if you were a kid and like you thought Knights and Dragons were like the coolest thing ever, like I did, or like if you played RuneScape or Skyrim or something, like you know what plate armor looks like, right? So anytime you got a pericarditis, it's like your heart is wearing armor or football pads or something. And like when it goes to move, its movement is restricted. So when the heart goes to fill with blood, it can only fill so much. And so some blood's going to back up into the venous system, right? Or into the right side of the heart or into the lungs. And that's going to give you the dyspnea, and that's going to give you the orthopnea. When blood backs up into the lungs, you get pulmonary edema because of a high hydrostatic pressure. And orthopnea, that means I can't breathe when I'm laying down, but then when I stand up, it's fine. Well, that's because when you stand up, you take some preload off of the heart. Your volume redistributes into your legs. So it gets better when these patients stand up. And so they sleep with a lot of pillows behind them so that they can reduce the preload on their heart. And a neck vein distension, well, that's when blood backs up past the right side of the heart into the venous circuit. And so you're going to have this bulging jugular vein that won't go down. And the neck vein distension represents, again, volume overload on the heart due to this restrictive pericarditis. The heart can't expand during diastole when it needs to. So we're going to treat this pericarditis typically with diuretics so that we can get some volume off, because that's what makes their symptoms better. So we treat the symptoms, and then the pericarditis tends to go away on its own. If it doesn't, we can do a pericardial centesis. So I thought this was cool. The pericardium can accommodate up to 2 liters of fluid. Yo, do you know how much 2 liters of fluid is? Jeez. If it's inputted slowly, if it leaks slowly into the pericardium, it can accommodate 2 liters, but you can't be too fast with it, because rapid accumulation of as little as 150 or 200 mils of pericardial fluid may lead to extreme symptoms right away. So the speed with which your pericardium is filling up is going to impact the degree of presentation it has, specifically acute versus chronic. 2 liters of fluid, yo. So there are types of effusion, and this is going to be basically what you see when you put a needle and perform a pericardial centesis. These are what you'll see. kind of a likely test question, basically, like how did the fluid get there? Actually, now that I think about it, super likely test question. There's 4 of them. They each have very different pathologies and reasons for being there. And so good test question. So hydropericardium, this is going to be just serous fluid, might not be serous, might have a low protein count, might just be watery. So this is going to be a transitate or an exudate, depending on whatever Starling's force is at play here. So we know that the difference between those is that with an exudate, there's going to be endothelial dilation, right? And then individual endothelial cells spread farther apart and they become leaky. You have a leaky endothelium with an exudate. And so protein can go in between endothelial cells, and that's why there's going to be protein in an exudate edema. Versus a transitate, the endothelium is not leaky, and so water goes straight through the endothelial layer, but protein doesn't. So there's no protein in a transitate. So either of those types involving Starling's forces can lead to a hydropericardium. You can see this in congestive heart failure, renal disorders. Why would you see it with that? Well, because you're holding on to volume, because you can't pass it out of your body. And so that's going to be a high hydrostatic pressure. Same with congestive heart failure, volume overload. Nutritional and hepatic disorders, protein insufficiency can lead to a low oncotic pressure, which means that there's not a lot holding fluid inside your circulation, which means it is free to diffuse across an endothelial layer. And so that's the low protein content there is the transitate component of it. Chylous effusion, this can happen with a chylothorax, which is whenever a lymph duct gets popped open and starts to spill into the pericardium. And it's going to be turbid because what's inside your lymphatics, all of the fat that you absorb from your gut and package in chylomicrons and send up to the thoracic duct to spit into the bloodstream. So that's why it's fatty. Serosanguinous effusion, sanguinous meaning like blood, and then serous meaning having protein in it. So this can follow chest trauma. Accidentally or caused by resuscitation, you got to break the rib cage sometimes in grandma or grandpa. Hemopericardium, blood in the pericardium. This one's really bad. Now, if you do this when you perform CPR, you really messed up. So typically a trauma, sharp penetrating trauma. This can be a complication of myocardial infarction. The ventricle can pop and start to spill blood into the pericardium. And if that happens, then you don't have a lot of time to work with. Can also happen due to a dissecting aneurysm because the layers of the aorta will split open and that will propagate down until it gets to the heart if it's a type A aneurysm. And then that's going to spill blood into the pericardium and presents as a tamponade. So what does a tamponade present like? This is big. You can put a star next to this, yo. You got to know the symptoms of a cardiac tamponade because it's an emergent condition and it's got a couple of characteristic things. Number one, I would say heart sounds get muffled, heart sounds go away because there's fluid around the heart, and so the sound doesn't travel as well through that abundance of fluid. Number two, cardiac output is going to drop. Patient's going to go into shock because they've got a diastolic dysfunction because it's hard for the heart to expand when it has to do so against the volume and weight and pressure of all that fluid in the pericardium bearing down on it. So no matter what the fluid is, you can get tamponade if there's too much of it. So when the heart's got a diastolic dysfunction, right? It means your cardiac output drops, but that means that blood backs up into your venous system. So you're going to get the jugular venous distension with this. You're going to get the dyspnea and shortness of breath. You might get an acute pulmonary edema from this. That can be a cause of death. So you get this sign called Kussmaul's sign, and this is pretty important because your jugular venous pressure, which you can visibly observed, but if you want to quantify it, you can put a right heart cath in, and so that might be in a question stem too. So your right heart pressure is going to stay very high even when the patient breathes in, and it shouldn't do that. And the reason that it shouldn't do that is because whenever you breathe in, typically you're expanding your lungs and your heart, and so you're creating a low pressure zone that allows fluid to move in there, right? But when you have a restrictive pericarditis, and a tamponade is a type of that, right? Your heart can't expand. So whenever you have any sort of diastolic dysfunction, but specifically in tamponade, you're going to breathe in, but your heart can't expand because of all the weight on it, right? Because of the fluid. And so even though blood should be going into your heart and thus your jugular venous pressure should be dropping, when you have a hemopericardium or a tamponade, you get Kussmaul's sign, which is a high jugular venous pressure because blood does not go in the heart whenever you breathe in because it cannot expand. So this goes hand in hand with pulsus paradoxus. So because blood can't go into the heart whenever you breathe in, what that means is that your cardiac output drops when you breathe in. And this means that distally, your blood pressure, your pulse is going to drop whenever you breathe in, and that shouldn't happen. So that's called pulsus paradoxus. So same concept, right? Normally your cardiac output goes up whenever you breathe in. And in the case of a tamponade, it will not do that. If you're looking at JVP, that's called Kussmaul's sign. And if you're looking at distal pulses, that's pulsus paradoxus. And then finally, the triad of a tamponade is called Beck's triad. You ought to know it. Hypotension, muffled heart sounds, elevated JVP. So we just covered all three of those, so you ought to know them. Now let's get into acute versus chronic pericarditis. And it's not very well defined here. To me, the big difference is that acute obviously happens acutely with big bad symptoms, and then chronic is going to slowly progress and it's going to have a more mild symptomatic progression. But other than that, I really can't tell how these two concepts are any different. You don't see an acute pericarditis too often. Chronic is far more likely. You could have a bacterial pericarditis. That's in this third image here. And if you're looking at the heart and it's yellow and covered in pus, then that's neutrophils, and that's going to reflect bacterial involvement. Otherwise, you can think viral pericarditis. If it's a watery heart, you might be thinking a serous pericarditis, and you can tell that there's a reflection or glow of light off of this thin, watery film on top of the heart in this one. This heart is red if you're looking at the color SDL, and because it's just blood red, you can feel pretty confident calling it a hemorrhagic pericarditis. And then your normal run-of-the-mill pericarditis is called your fibrinous pericarditis, and in fact, it is called the bread and butter pericarditis. And this pericarditis here, the first one on the left, is the same one that we have seen already in rheumatic heart disease because, again, it's run-of-the-mill, it's fibrinoid, and all that fibrinoid material is going to be collagen and extracellular scarring just getting deposited over the course of a very chronic inflammation. So this is using words to explain the different types of pericarditis. I think this is also a likely spot to draw a test question from because, again, there's 3 or 4 of them and they're pretty different. So if you get a fibrinous pericarditis or a serofibrinous pericarditis, what does that mean? Well, there's an inflammation of the pericardium and it's got a fluid in it. And it can either have protein or not. And it's going to have a fibrinous material in it. So if it doesn't have protein in it, it's going to be a transitate. And if it has protein in it, it's going to be an exudate, right? So whenever you have a localized inflammation, that signals to your blood vessels to dilate and to become leaky, right? To promote the immune response to whatever the inflammatory pathogen is. So that's what gives you an exudate, is the leaky endothelium. And looking at all these causes, most of them are inflammatory in nature. So Dressler, autoimmunity, right? Is there inflammation associated with autoimmunity? Yes. So would there be a dilation of capillary beds? Yes. So they'd be leaky and it would be a serofibrinous pericarditis. Uremia, that's too much nitrogen in the blood. Well, nitrogen's a component of proteins, okay? So you're going to have nitrogen being pushed across into the pericardium, and that's going to give you this serofibrinous exudate. Chest radiation. Can that cause local inflammation? Yes. Radiation is going to cause the generation of free radicals, which can irritate endothelial cells, cause them to dilate, and cause them to become leaky. So you get a leaky endothelium with any targeted radiation. Rheumatic fever, autoimmunity, immune reaction against cells of the heart. So anytime you have an immune reaction, are you generating inflammatory cytokines? Yes. So is the capillary bed going to become leaky? Yes. So if it becomes leaky, is that a transitate or an exudate? That's an exudate because now protein can fit through. SLE, that's an autoimmunity. Is there inflammation? Yes. What happens to the endothelium? It leaks. Is that a transitate or an exudate? Exudate. Chest wall trauma. Yeah, that can cause inflammation. So it doesn't really explain what the fibrinous reaction is, but my assumption is that it's the basic and general scarring response to any sort of injury, right? You're always going to scar to heal up an inflamed or injured region of tissue, and the fibrinous material in the fibrinous pericarditis is a byproduct of such collagen deposition and normal natural healing. So purulent pericarditis, purulent pus, bacteria, neutrophils, and it can directly encroach into the pericardium from neighboring tissues, or it can extravasate from the bloodstream. Hemorrhagic pericarditis. Similar to a hemopericardium, except it's a much smaller scale. Your capillary beds are going to be leaking minute quantities of red blood cells into the pericardium, and the gradual accumulation of these blood cells is obviously going to tinge that fluid red, and this is most often caused by a neoplasm associated with leaky endothelial capillaries, right? Because that's what the cancer wants, because it wants to metastasize and spread, and it also wants to get an abundance of growth factor from the blood. All those metabolites, the cancer wants a lot of that, and so it vasodilates everywhere around it. And the vasodilation is so intense that blood cells start to leak through. That's your hemorrhagic pericarditis. So there's a section on clinical presentation. You're going to get a chest pain. Worse when you breathe in, worse when you sit up in bed. You get a friction rub. We know about that. There are some ECG changes, but you're not going to be asked to make a diagnosis on this test just based on the ECG alone. If you've got just a pericarditis, X-ray checks out, it's normal. Because even though there's a bit of fluid in there, there's no swelling. But what you ought to know is that if you take a CT, an axial CT, then you can see a thin strip of fluid going all the way around the heart anytime there's a pericardial effusion. So acute pericarditis may follow a myopericarditis, or it can have a subsequent myocarditis. And so anytime there's inflammation, it's tough to localize it to a particular layer of the heart. Lab studies are non-specific. And wrapping up acute pericarditis, in the special case of TB, you can get pericardial calcifications. And that's going to show up on an x-ray, of course. And it's going to be around the outline of the heart, right? And your patient's going to have active TB, so they're going to be coughing their head off. They're going to have these granulomas. They might be calcified within the hilum of their lungs and within the lower lobes of their lungs if it's active TB. So you're going to see coin-shaped round lesions in their lungs if they have TB, along with this pericardial calcification. And if you do a pericardial synthesis, it's got a high protein count and it's got a lot of immune cells inside of it. But if they have TB, you should be able to put one and one together at this point. Let's talk about chronic pericarditis. So in an acute pericarditis, because it's got such a sudden onset, we're typically going to be able to catch the patient and implement some preload reducing therapies so that their heart doesn't have to work too hard. And then if all's properly managed, then the pericarditis will most typically burn itself out. But with a chronic course of pericarditis, we sometimes can't catch the inflammation of the pericardium until it's too late, right? And so if we can't administer anti-inflammatories and that sort of scarring of the pericardium is allowed to continue, well, scarring is irreversible. And so instead of just one episode of pericardial inflammation, what you now have in a chronic pericarditis is a lifetime of pericardial inflammation. And again, with the scarring of the pericardial layer, that pericardium basically gets pasted to the outside of your heart. And so that's really bad, because that's going to be called a constrictive pericarditis, and that's going to be a diastolic dysfunction, because just like a suit of armor, it's going to inhibit the expansion of your heart every time it needs to expand in diastole. So the differential for this is going to be a restrictive cardiomyopathy, which presents very similarly with diastolic dysfunction and volume backup. Pericardial adhesions are like isolated plaques, and then as it progresses, it goes down to 2 really, or it can go all the way down to 3. So it's kind of a timeline. Mediastinal pericarditis is bad, but I don't think that there's anything besides the phenomenon of the rib cage pumping with the heart that particularly sets it apart from a constrictive pericarditis. In fact, I would go so far as to say that adhesive mediastinal pericarditis is a subset of constrictive pericarditis. So the easiest way to make this diagnosis is if the patient's already had one pericarditis, because then you know it's going to be a chronic pericarditis. And it says here in the text that constrictive pericarditis is typically a sequela of an acute pericarditis. And because this may be subclinical, this may present as the patient's first bout of pericarditis because they didn't know that they had it the first time. What's going on? A lot of collagen gets laid down inside the pericardium, which we know is that layer between the heart and the tissue surrounding the heart. It's a fibrosis and a thickening of this layer, and this constricts diastolic filling. So all the symptoms and worst case scenarios and consequences are downstream, secondary to the diastolic filling. Now, no matter how you get pericarditis, it can develop into pericardial constriction, which makes sense. This is a general etiology of scarring, right? And you throw down collagen in response to inflammation. There's nothing special or specific about it. This is always what your pericardium does whenever there's nearby inflammation. So viral pericarditis is going to be a precursor about half of the time. And then cardiac surgery is highly correlated with the development of chronic pericarditis. And the reason for that is because if you do open heart surgery, you have to cut through the pericardium in order to cut through the heart. And so whenever you do that, you sew the pericardium back up. Well, if the if the heart doesn't like it, then that pericardium will swell, become fibrotic alongside all that inflammation around the side of the cut. Also, chemotherapy, mediastinal irradiation can cause inflammation in the pericardium, causing nearby cells to throw down collagen, causing fibrosis of this particular layer of tissue. Again, because of the dense scar, hypertrophy and dilation cannot occur. That sentence is crucial. I mean, that's a theme that we've seen throughout this entire text. So here is a pericardium that down here at the bottom of the picture is kind of fused to the myocardium. If you zoom in, you know, there should be a nice separation between these two borders or between these two layers, but like especially right here, I mean, they're practically touching and there's no space in between them, and there ought to be. And so it's hard to tell you in words, so I'm not going to try to. The difference between a normal and a gross pericardium, especially since we haven't been able to get into the lab. You just use your best judgment and remember to check out all of the landscape whenever you're given a gross slide. Don't ignore any of it, and don't bird dog in on an answer before you've looked at the whole picture, because that was a very good question on our last pathology test. There was a hemopericardium, right? And it presented as this big thrombus in between the pericardium and the muscle of the heart. And if you were really gung-ho to say, oh, this is an acute MI, and you called it a wall thrombus, well, you were dead wrong, because, again, it was inside the pericardium. So if you didn't look to see that pericardial layer on the outside of it, you would have called it a wall thrombus. This B, that's a terrible rectangle. This here in image B is containing an elastin stain. And so it's staining for fibers, basically. And so this is showing you how dense the fibrosity of the pericardial layer is in this particular heart. And then, yo, this is fascinating. Man, because it's like you can almost picture yourself like picking these things up and like banging them on the table, and they make a sound like a rock. Like those are clearly sclerotic, calcified fragments. I mean, it's a fragment of pericardium, like it's pottery or something. That's absurd. So that's the degree to which this can progress, you know. So you see this picture and it's like, you shouldn't even have to read the 3 pages beforehand, because it's like, oh, that can happen to your pericardium. Well, how does it happen? Anytime there's trauma or inflammation localized to the pericardium. There we go. Can it spread there through the myocardium? Yes. So that's it. That's how you get pericarditis, you know, like in a nutshell. It's either going to start in the myocardium and spread outwards, or it's got to be some sort of trauma to the pericardium. This can be a cut, surgery. This can be dissection, aortic dissection. This can be an arteritis, vasculitis, right? This can be an autoimmunity, as in the case with the Dresslers post-AMI, right? Autoimmunity specifically against the pericardium. What about exogenous sources? Radiation. That's going to cause a lot of focal inflammation if you're trying to target a mediastinal tumor. Everything makes sense if you just work forwards or backwards, know where you're starting from, know where you're going to. And with these test questions, I mean, you're smart enough to fill in all the spaces in between as long as you know where you're starting from and where you're going to in each of these pathologies. So this is time for an interesting talk. So the pathophysiology section talks about the square root sign in the left ventricular pressure tracing, right? And the reason this is important is because there's one other pathology that looks a lot like constricting pericarditis, and that's restrictive cardiomyopathy. And you're going to see the same things: diastolic dysfunction, volume back up into the lungs, into the right side, but they're very difficult to tell apart. And the way that you do so is by putting a catheter into the left side of the heart, which is not something you want to do unless the patient really, really needs it. But if you catheterize the left side of the heart, or I suppose you could take wedge pressure as a proxy for left atrial and use that as a proxy for left ventricle pressure, right? So basically, in a constricting pericarditis, your myocardium is fine, but your pericardium is stiff. And in a restrictive cardiomyopathy, your myocardium is diseased. It's inflexible, but your pericardium is fine. So again, with both of them, trouble filling the heart all the way. In pericarditis, due to the pericardium being that suit of armor, but in restrictive cardiomyopathy, because the wall of the heart can't relax. So you take a pressure tracing of the left ventricle and you plot it over time. And what you see is that with a constricting pericarditis, let's say that this is the start of diastole. I'm going to go with a different color. Here's the start of diastole, and then here's the end of diastole. You see that most of the filling of the left ventricle is going to take place right at the start of diastole, because there's nothing wrong with the heart, nothing wrong with the muscle of the heart. When you start to put blood in it, it'll accept blood. It's just when the heart expands to the point where the pericardium can't expand anymore, your filling just stops. And so you go flatline in that last section of diastole. And this is compared to a restrictive cardiomyopathy in which the heart muscle has a really tough time expanding. So even when you have atrial contraction or rather passive filling at the start of diastole, your heart's really slow to fill up. You see that it's got a slow slope upwards. And then by the end of diastole, maybe you've filled enough to pump some out. But the main difference between the pericarditis and the restrictive cardiomyopathy is going to be in the first third of diastole, because you don't have any myocardial problem with the pericarditis, so you can fill up a lot. But then you hit a wall, you hit a plateau again whenever your pericardium says, I can't flex anymore. But then with the cardiomyopathy, the pericardium's fine. It's just you got a tough time getting your muscle expanding to start with because it's stiff. So I know that most of you probably don't give two pennies about that, but that's how you make the differential. So you can get calcifications in a constrictive pericarditis. And specifically, these are going to be calcifications in a patient with TB. They tend to go hand in hand. You see some patchy lower lobe involvement down here. You see a kind of a coin-shaped nodule at the hilum of this right lung. And then you see kind of a smaller one over here too. And those are called Gone complexes, or at least they're the development of them. And then if you take an axial CT here, you see there's the anterior pericardium. And then here's the infralateral pericardium. And the high signal on CT means it's high density, so it's calcified. One more point about the heart cath. Again, it's called the square root sign, what we just looked at up here, because it's shaped like a square root because it goes up and then it plateaus. And the reason it plateaus is not due to the myocardium, but due to the pericardium constricting it, versus the restrictive cardiomyopathy, which is not a square root sign. It's more like a Nike swoosh sign. So constrictive pericarditis, as you can imagine, it's really, really bad if you can't fill your heart all the way. It pushes you into heart failure. And again, it mimics a restrictive cardiomyopathy. You got a low cardiac output and you got a venous backup. And combined, this is a very common cause for needing a new heart, a complete heart replacement. In fact, I'm pretty sure that I read that pericardial effusion is the number one most common cause of needing a heart transplant globally. So that's your pericardial diseases. Types of effusion, again, just because there's a multiplicity of them, and they each have clear, distinct, well-demarcated pathologies in between them. You know, that's a common source of a test question. Knowing diastolic dysfunction is big. Recognize tamponade, be able to make the tamponade diagnosis. And then acute versus chronic is going to be the progression of symptoms. Remember that it's just the deposition of fibrous material, scar tissue, collagen in both cases. And it's typically following a viral pericarditis or some sort of injury to the pericardium. And that's it.